It's really my privilege and honor to introduce our keynote speaker. And the topic is really important to us here at UCSF as we work harder to support people in their lives and their health outside of the clinical setting. And the topic is telemedicine or telehealth. The names change often, but we keep working steadily in the field. The chairman of our telehealth committee is here today, Dr. Seth Boxer, over in this area. So if you have questions about what we're doing here at UCSF specifically, please seek him out. But at this point, it's my great honor to introduce Dr. Reed Tuckson, who is a leader in internal medicine. He's been a leader in public health and health administration, and now he's the president of the American Telemedicine Association. And we're extremely excited to hear what he's going to talk about. He's going to set the stage for the whole day and cover broadly this industry that we're referring to now as digital health, and how that intersects with telehealth. And I would like to also say that he's going to do this in such a broad fashion. What he called was hitting the top of the trees, and I guess because I'm on this coast, I call it hitting the top of the waves, but it's going to be a great experience to set the stage.
Thank you so much. I appreciate it. Instantaneously, they're going to turn this mic on. And then magically, there's this great guy who's got all black on. You don't see him. He's going to plug in the thing that lets this work. We'll find out. If not, I'll be doing this without a net, which is awesome. Let me say by way of introduction that I am honored to, first of all, do anything that Jill Miller says she's supposed to do. Scared the hell out of me, so I don't know how I do. She's wonderful. But also, actually, to be able to be around you innovators. I have such admiration for what it takes to build and start businesses in health, any sector of health, but especially in this sector. You are to be admired for your willingness to take on really tough but hugely important problems. I am, from my perspective, excited that we are finally moving into the mainstream. It is amazing the speed with which our fields are being adopted inside of the delivery system. But that means that there are important opportunities and important challenges associated with it. But at the end of the day, the thing that is so key, we must keep in front of us the larger purposes and transcendent values of the work we do. I hope a lot of you are not people traditionally from healthcare, because Lord knows healthcare needs people coming into it who have no real idea about healthcare. We need new deputies in this fight. But for those of you that are not from the health world, let me just quickly remind you that when you self-select to be concerned with whether people shall live or whether they shall die, and the quality of that survival, you are entering into very sacred territory. You are entering into issues that are at the heart of the American democratic civilization. Jill does everything. We're having all kinds of problems with the mic. It was such an important point that I was making. This doesn't count against my 35-minute thing, because they're vicious with you on the time. So I keep going. Okay. Let me go, even though we had the comic relief part, let me get really serious about this point, because it's fundamental. When you are concerned with whether people shall live or die and the quality of that survival, you really are in a very ethically important world, a world that is governed by fundamental ethical accountabilities that are at the heart of what it means to be in a civilization. And so there's a lot at stake. I have very little interest in innovation for innovation's sake. You may have created the greatest napkin folder in the world. Whatever your thing is, terrific, good for you. But at the end of the day is, does it make a difference? Is it important? Does it help us to move forward? And that's always going to be key. There needs to be an organizing vision, a sense of what is this new world of healthcare that you are going to usher in and facilitate its realization. I think we are clearly now moving from a world of physician and hospital-centric care. We're clearly, as you know well, moving away from a world that is focused on medical care as the fundamental element of where we are doing our work. We are now in a world of patient-centric care, and we are moving from obviously, it's almost become a cliche now, a medical care system to an integrated health and medical care system. The person is at the middle of the picture today. And how we activate or empower that person is key. And that'll be the theme of much of what I say today. Around that person are fundamental new determinants. Lay health workers, key players today, never been in the equation before. They would have never seen themselves in the class picture. Now they're in the class picture. Community engagement, early disease detection, primary care team, specialty care, how we use biotechnology, how we use hospitals and nursing homes, how we engage social support. You see the refrigerator with wheels on it? That's Meals on Wheels. Isn't that great? I did that. Very hard to read. And then, of course, in-home care support. All of that vision coming together around an organizing ethic that most people are really getting engaged with. Thank you, sir. And that is this idea of the triple aim. The triple aim is a fascinating concept started by people like Don Berwick. And what's fascinating about the concept of this triple aim is the stakeholders in healthcare who have adopted it as a visionary model. The device manufacturers, the delivery system, physicians and hospitals, policy wonks, everybody seems to have gotten on board with these three pillars. What's particularly interesting about this triple aim is not only are we focusing on improving the health of the population, enhancing the patient experience with care, quality, access, and reliability, and reducing the per capita cost of care, but something else is happening that's very interesting. And that is we're beginning to move, and this is fundamental for the strategic visions of your companies. We're moving towards this integration of population health and more person-focused individual health. And these two movements are occurring simultaneously with great impact to you. But at the end of the day, whatever we're doing, it's all about every sector in healthcare producing value. No one anywhere in healthcare escapes the value determinant conundrum. It is the 800-pound gorilla in every conversation. And so if you start to then take this forward, not particularly, I don't want this to appear a busy slide, but trying to visualize this sense of this integrated individual and population health model. And you can sort of start upstream with the community-based environment, the social determinants of disease, housing, education, quality of the water, and then the physical environment. So those two together on the upstream. And then combine that with the individual's genetics and certain physiological factors, which are heavily then influenced, and this is again key for your world, behavioral factors, the things that determine how people act, but also key things, factors like resiliency, spirituality, all very important determinants. We combine these etiological factors within the environment, the toxins that are in our environment, the negative forces with individual elements, and ultimately you wind up then with disease occurring too often, disease then needing to be managed. We either get to restoration of health, more likely chronic care management, unfortunately at times mortality. At the end of the day, this continuum is operative, and into that continuum emerges what we do. This is a slide that I adapted or borrowed from, stole from my friends at Nuvian, another company in our space. But it's a very interesting depiction. And what they tried to do in a very busy slide is to show the synergy between the digital health technologies, the telehealth technologies, data, health IT,
personal genomics and gave it some weight in terms of the amount of energy in each of those spaces. But combining all of that together as a new set of armamentarium designed to reach larger purposes and transcendent values, coming together for the health of each individual person. Now, what makes talking to you about this difficult is because many of you, in different camps. Some of you are in the clinical digital space, some of you are in the consumer digital space. Inevitably, this is going to happen. I don't know how much these circles or these shapes are going to overlap, but at the end of the day, we are going to have to see much more of a convergence of these two. Regardless of where you are on this page, you cannot escape two key words: trustworthiness and predictability. People have to know what it is that you are doing and whether it works, and be able to know how much they can predict how it will behave. So there are key factors that are working on our behalf. One, of course, is cost escalation. I know you know that costs are a problem, that it gets discussed everywhere. What I cannot emphasize enough is how determinate the cost escalation problem is. It is absolutely freaking out everybody. There is no employer buying employee health insurance that can afford any more cost increases. And damn sure no small business owner anywhere in America can afford any more cost increases. No state government can afford any more costs for Medicaid. The budget for Medicaid looks like this. The budget for K through 12 education looks like this everywhere in America. We have destroyed any chance of our children having a rational, reasonably robust education system on the backs of paying for health care. It is an untenable situation going forward. And then there's Medicare, which of course is terribly in trouble. What's interesting is, unfortunately, new evidence that health spending is increasing very rapidly again after slowing down. First quarter of 14 versus first quarter of 15, this is what healthcare expenditures start to look like. And why is it going on? A lot of it is because the economy is better. It looks as if a great deal of the slowdown we saw a year ago, a year and a half ago, was because of the economy and because people not making discretionary decisions. Now people are beginning to make discretionary decisions around health. That's kind of good for some of you in your businesses. People have more money, are willing to buy more things, but it certainly is putting huge pressure on costs, and greater efforts will be needed in the future going forward. And this is really determinant for digital health. This out-of-pocket exposure to health costs by the average American family in relationship to their wages, that gap is going to increase year over year. And so at the end of the day, does anybody here believe that wages is going to go up on that bottom line and compensate for that? It ain't happening. And so the American people are now in the bullseye. And increasingly, with insurance copayments or other forms of shared risk, or restated another way, shared incentives, the individual is going to be sitting at their dining room table on Sunday night trying to figure their way out. What that also means is that increasingly now the average consumer can no longer decide that there's a boogeyman somewhere paying the bills for them. They're paying the bills increasingly. And now it's very, very personal what happens from this point on. The cost problem is going to get increasingly challenging because of the way the delivery system is working. We had outpatient oncologists, for example, in an inpatient setting, and now the inpatient setting is buying up the oncologists and bringing them in the house, changing the dynamic of what was getting paid for on the ambulatory side to the higher costs on the inpatient side. Very, very costly kinds of movements are occurring across the relationship between hospitals and docs. But here's the issue in oncology. Good news, bad news. Good news. Man, we got some unbelievable therapy for cancer. It's working. We are making huge progress. Bad news. We got a lot of people who are going to survive a long time with the ravages, not only of the disease, but the consequences of the medicine. Somebody is going to have to manage 18 million people in a couple of years who are living with complex medical problems associated with the side effects of medicine that has saved their lives. There is a big market here that someone will have the opportunity to address. Breakthrough drugs are going to bust the bank, inevitably. 10 new breakthrough drugs are going to increase Medicaid spending by $31 billion. Read my lips, no more taxes. What do you think is about to happen as you begin to look at what's going to happen to the Medicare program in the future? Medicaid costs. And what are the drugs? They're for a combination of cancer, but also for lifestyle-related disorders, population-based and individual prevention issues. Hepatitis C, breast and lung cancer, diabetic retinopathy, and so forth. And then there are 2 new cholesterol drugs that just got approved a couple of days ago that will absolutely break the bank. And so the point being, who's going to help people prevent the need for these drugs and then use them, keyword, appropriately? Who's going to help figure this out? And what will the tool set be that will address this opportunity? This hepatitis C drug was the one that scared everybody to death. I know all of you are sophisticated and have heard about Sovaldi at $100,000 per, when you add it all in, per patient treatment episode. The thing about this drug, which is so frustrating, is the disease that it's treating is hepatitis C. And how do you get hepatitis C? Overwhelmingly, they're people that are abusing drugs. So we're back to a prevention issue here that is so important. How do we turn the spigot off? So there is this tsunami of preventable chronic illness. I love this slide. Watch this. This is so cool. Can I make it work? A tsunami of preventable chronic illness washing over a delivery system that we cannot afford. And that's fundamental. Look at the numbers. This is America's health. This doesn't get doodly squat conversation. Every once in a while, somebody goes, oh, yeah, we got to have this prevention thing. Somebody will, every once in a while, remind us that Michelle Obama, is trying to talk about it. It doesn't, who's the Surgeon General? You don't hear it anywhere. There's no conversation really about prevention, not at the level of scale. We're 40th in the world in whether our babies survive. Who's got an app for that? Can you believe that still 19.6% of Americans still smoke tobacco? Inactivity, 23%. That's up significantly from last year. Obesity, 28% almost. Diabetes, almost 10%. That's the issue. But if that weren't bad enough, we have the problem with Medicare. Look at what's happening with our seniors. We are living longer. Good news. Bad news. We're living longer sicker. Not good news. And so you see the numbers there. More than half of all Medicare beneficiaries have high blood pressure, 25% have diabetes. The active aging market for you is 20 million people. So significant numbers of people, obviously, for you that are interested in what you're doing. But here's the real challenge. It's not people with one disease. It's people with multiple diseases. It's the combinations that are really going to get complex. So as you are designing new innovations, the question becomes, how do you address people who have multiple challenges? And how do you support the caregiving system of the people that are trying to manage that? What that means, first and foremost, and it's something that people, again, don't talk about, is if we're going to deal with prevention effectively, we've got to be inside of the community. Community environment. I have spent half of my life working to try to get communities engaged in a data-driven conversation about health priorities where they live in their environment. And you know something? It's damn near impossible to do, and when you can do it, it's damn near impossible to sustain. There ain't no more back fence. There's no community gathering place. People don't get together like they used to. So that's the bad news. But the good news, you taught us. You taught people like me that, hey, our social networks are probably as determinant in affecting individual behavior as our geographical environment. So you've taught us a lot about the power of social networks. What I have yet to see effectively done is to apply that into a local geographical community conversation and have tools that facilitate conversations among church, civic association, fraternity, sorority, business leaders, public health department. How do we have that conversation using the innovations and tools that you make? I'm pleading with you. Please, somebody invent the way to have that conversation sustained so that communities can actually take data such as this from America's Health Rankings, which is one of my projects, and take that data and translate it into effective community planning for health at the local level. It's a big opportunity that is also moving forward is, in addition to the cost issue and the increasing preventable chronic illness, is the crappy quality of health care. Now, I like docs. One of the jobs I used to have was I was the doc for the AMA. I'm all in for, we're good people, great docs, terrific. Guess what? The care we provide sucks. Half the time inconsistent with the best scientific evidence. Not because doctors are bad. No one in my medical school fought to be last in the class. Well, except for that one dude, but then we sent him to San Francisco. It's complicated to be in medicine today. We started with the Ares Human. We found out that we were killing 48,000 to 98,000 people in hospitals on a regular basis. We then followed up and began to understand crossing the quality chasm, which literally is what the title says. There is a chasm when it comes to quality. If you have not read these reports, go immediately to the IOM website and read the executive summaries of crossing the quality chasm. It will do you no harm and a bunch of good. You'll be shocked to see where your face is in the class picture in 2001. What you will also be dismayed to see is how little progress we have made since 2001 in implementing these recommendations. And then the last in that series was this greater best care at lower cost, which tells us that because of the waste and the misuse of healthcare assets, we waste $750 billion. You do not want to be in this class picture. You do not want what you do to contribute to that statistic. And so we have this quality environment. Health professionals live in a complex environment. They are deluged by mandates, by coding systems, performance standards, data, incentives, and penalties. We have to find a way to work with them. It is so important to be at UCSF and other places like this that are training and teaching the next generation of physicians to be able to understand. Most docs do not know anything about what you're talking about. They have a doodly squat idea, and they don't have time to figure it out because they're busy with other things. So we have to connect physicians and hospital leaders to the best thinkers and innovators. I put the hospital leaders there because the CFO of the hospital is a fundamental, obviously, rate-limiting step for many of your businesses, and we have to teach them. We have to disseminate best practices and create learning laboratories. We should be sending every doc on a regular continuing medical education opportunity into UCSF so that they will then get the best practices of how your tools can be used effectively and efficiently and make it easy for these people to figure it out. Beware. You got good stuff. I got so excited by the blood pressure cuff on my iPad. Now imagine each of us send our docs a gazillion pieces of systolic and diastolic data on a regular basis. You'll blow them out in a day. It won't work. So the question is, how do we not have the doctor's office look like the air traffic control tower? And so obviously one of you has got a business that will be an intermediary and figure that out, and you'll figure out how to take all that stuff and organize it into an easy to use, simple way for patients to send complex information into a doctor's office, hand it to the doc, in-flight refueling as they go from room to room, and you'll make it easy and you'll make $1 gazillion. So good for you. Interoperability and data integration are obviously important. And so we've got this fabulous world where all these patient tools and physician tools are now available and they're all coming together. How do we integrate them into the delivery system? And so there was a reception yesterday, and it was the moderator said that if you said the word big data, you had to drink alcohol, drink a shot. So I'm sorry, I had already made the slide, lady, so you have to forgive me. But clearly, we have learned a lot about how you can take claims, lab, and pharmacy data and tell a story about Mrs. Jones. 35-year-old African-American women with diabetes and congestive heart failure. And you can tell that story from that. But now, of course, where the excitement is and where the innovation comes is being able to take health risk assessment, health screenings, electronic medical record, biometric data, mobile health apps, coaching data, care management engagement, and squash all of that together, liquefy it in some sort of format so that you can pour it into the delivery, run algorithms and pour it to make real personally appropriate health choices and decisions for individuals. This is not sexy, and it's awfully hard. And whoever has to do the calculus to make sense out of that data set that were never intended to go together is an absolutely wonderful set of people, and we have to love those people. I don't want to be the person to do it. It shouldn't be so damn hard. It should have been easier. So the Office of the National Coordinator has now their latest proposed rule. You guys need to be much more active and engaged with ONC to fight for what you need in terms of interoperability of the data systems and the systems that will allow interoperability of the devices. Remember that that the Office of the National Coordinator is a political entity responsive to politicians. So whenever there's a movement to move apparently too fast to be able to get things integrated, you get 260 congressmen being asked by constituencies to write a letter to ONC saying, stop, slow down, you're going too fast. So entrenched big-time interests who have been from the old world, not the new world, can really screw you up because you guys aren't in the drama, and you need to be in the drama in a much more exciting way. Just in the last few days, providers want CMS to slow down the EHR superhighway. IT experts tell Senate to nudge, not legislate, for interoperability. Use persuasion. Just the other day, I think 2 days ago, on the 16th, big meeting with Senator Lamar Alexander, and he's basically asking the question of our community, would it be wiser to slow down the finalization of their rule, or would it be better just to push ahead? And the witnesses, at least at this table, finally said, no, you need to keep the pressure on and keep moving. Why did the witnesses say you need to keep moving and moving forward? Because they're saying we've got to respond to 129 quality measures that describe how well we are performing. We can't do that without interoperable EHRs that will allow us to move forward. And secondly, we need to be able to improve patient outcomes with all the tools available to us. You can't go backward. And so I think you need to be thinking about what organizations you are with that will help to put pressure to move forward with much more speed. The genomic medicine curve is critical to you. Every time you hear the word precision medicine, your ears should light up. Precision medicine is this idea now that we will provide care based on the unique genomics of the individual, right treatment, right time, every time, right person. The head of NIH, Francis Collins, talks about this exciting world of advancement in data science, computing power, electronic medical records, and the dramatic drop in the cost to sequence the individual's entire genome. Let me tell you something, ladies and gentlemen. We now can go ahead and typecast your entire genome in a day for very little money. The problem is you got so much information and you don't have any idea which of it is really significant and which isn't. So it's presenting huge conundrums of how to make sense out of all that. Now, by the way, I used to be the head of the Secretary of Health's Advisory Committee on Genetics, so I'm not against this. I love this stuff. I'm also on the Advisory Committee to Francis Collins. I love this stuff. It's great, it's exciting. But the point is how do you make sense out of all of it? And this is where the challenge is going to be. By the way, one guy commenting on this started to talk about, he says he shows a slide about treatment that can cut the risk of converting from prediabetes to diabetes by nearly 2/3. It's called diet and exercise. But that ain't very sexy. So we got to sexify up your stuff, I guess is the point, some kind of way. But here's the deal. This is the genomic era. The number of facts per decision gives you that kind of curve as we get more complex in knowledge around genetics. What's exciting about that is, it really gets complicated. Here's what's not good. Human cognitive capacity ain't gone nowhere. We're just as dumb today as we were before, and we ain't gonna get any smarter. Do you see an opportunity for you and your businesses here? Somebody is gonna have to figure out how we make the aids and the supports to be able to make decisions. This is the growth in genomic testing alone that we will see over the next few years. It is huge. And so Angelina Jolie appears on the scene and makes some incredibly important personal choices, not based on whether she has a thing or not, yes or no. She's making decisions based on statistical probabilities of having something happen to her. A very complicated set of decisions. Let me ask you a question. How many people in your world, not the people in your academic world, but in your normal life, have ever had a course in statistics? How many Americans have ever had a course of statistics in high school? Who do you think is prepared to make these kinds of difficult challenges? And guess what? There are only 18 genetic counselors in the country. Well, 108. There are very few genetic counselors for the demand curve that I just showed you. So, a challenge, but within it is a huge opportunity. How do we act on a patient's needs and values? How do we capture it? How do we think? By the way, when a woman decides to get one of these tests, in many cases, especially ones for breast cancer, not only is she going to find out what's important to her, but her sisters are going to find out also, even if they didn't want to know. So guess what? Everybody's stuck in the mud at the same time. How do you get at human beings' personal needs and values? You in the digital health world, a lot of you are very close to individuals. So you can capture, you can teach, you can counsel, you can create a lot of new mechanisms. Somebody's going to have to do it. And then, of course, you're going to live a long time with some of these diseases. And so how do we then coordinate all these various pieces of the puzzle so that the lay healthcare workers and all the rest of the system can work around the individual? This is an unmet need that is extremely important. And guess what? There is nowhere in the delivery system that there is accountability to make that puzzle come together. There is no one's job. It's not the health plan's job. It's not the hospital. They don't see it as their job per se. The doctors doesn't see it as their job per se. Making sense out of this puzzle around the person is left sort of a little bit here, a little bit there. Somebody can come in and needs to own this space and make this puzzle sort of come together. It's a huge opportunity. Then we've got to make a decision about this relationship between the individual and the people that are caring for them. A lot of the world, as I have indicated, and my bias is strongly around empowering. 4 minutes. Whoever's keeping track, I know I got like 5, 6 minutes. But they took, I get 3 minutes back because of the microphone. The point being is that there is a sense of empowering the individual, which is key. But you cannot move the American vision of what a healthcare, integrated health system is going to look like if you're not connecting it to docs or to health professionals of many different disciplines. And so what is this, how do you provide the clinician and the patient with meaningful information so that they can together make appropriate choices and decisions? Well, first, I think you all read about the case in Texas where the medical board has said that that telephonic only engagement is not adequate for a first encounter with a patient, that it must be that you have at least physical eyes on the person in the same room or at least video. So it's a big uproar around what is appropriate use of these tools. That decision was stayed by another judge, so it's left in limbo for the moment. And we at the ATA, as an example, are spending a huge amount of our time trying to think through how do you separate out and give rational guidance to the American people around appropriateness of their relationship with healthcare professionals and providers. This is one that is going to be very difficult to work through, but very important to you. Meanwhile, also with state medical boards, one of the things that they are doing a pretty good job of is protecting individual turf in states. And they're making it very difficult for interstate licensure, so that if you are a doc in Wyoming and you're doing telehealth or digital health engagement with somebody in New Mexico, they're making it very difficult to to be licensed to be able to perform that service. We're fighting hard. The economics associated with this are huge. There's an economic incentive for medical boards and a political incentive for them with their friends in their town to be restrictive, and we're trying to fight very hard. The Supreme Court is made some important decisions about medical boards and how they are comprised, and essentially made the observation that when you boil it down, some of these are nothing but restraint of trade opportunities. So this is going to be a big issue. What we need is reciprocity, and that becomes very important. We have to, though, have clinical guidance for those things that are clinically significant. And so again, at the ATA, we're putting a lot of effort and energy into developing clinical guidance that health professionals can use for how they interact and use new tools with their patients. But at the end of the day, we've got to get doctors, associations, and federal agencies involved to give us the research to do that. Appropriateness criteria is key. And so I was surprised by this attack. Now you get the abortion rights people angry at our capabilities because people now can use this somehow to be able to affect abortions, especially through medication. So now we're going to be attacked, and that's just going to be an interesting opportunity how this plays out. But here's what I really want to focus on as I start to close out, and that is I really do respect people. I respect the intelligence of the American people, and I respect the values that individuals need to be able to make personally appropriate choices and decisions. I think it is really critical that we're able to provide them with information that's rational to make good decisions. But one area that really throws me off, and I don't know how to deal with it, is like things like vaccine, where you get people who are theoretically very intelligent, who read the literature voraciously, and decide that they can take my grandkids and put them at risk because they won't put their kids to be able to do vaccination and destroy herd immunity. That pisses me off. So at some point, I'm really like, is the patient, is the individual always right? These are tough issues that a mature society will have to learn to grapple with. What I hope you are able to do is to provide the information in a way that leads people to make more evidence-based decisions as opposed to modern mythology-based decisions. Consumer behavior change is the coin of the realm, and that's really where we have to go. We have now the data that tells us who we need to talk to. We know Mrs. Jones didn't get her mammogram, and she's of the right age. We have the data that tells us, Ms. Jones, you didn't get your mammogram. We know not only we need to talk to her, but we know what we need to talk to her about. The problem we don't do a good job in medicine, this is why I'm glad that many of you in this room are not from healthcare, is we don't know how to talk to Mrs. Jones. And so all that data that we had before, let's be able to run algorithms against that, just like the consumer companies do, like the rest of the people in the Bay Area do, and be able to do preferred individual engagement strategies. So we know about how to engage these people to be able to make better choices and decisions. And ultimately, it's the combinations of individual encouragement, social competition, collaboration, and feedback loops. So we can get seduced by all these tools that float around us. There's a lot going on in this room. It's all terrific. But the only thing that really matters to me is how does it affect human cognition? And so that becomes the point. Well, I think I'm probably right on the dividing line. Let me just take 2 minutes and not do slides, but just to make two concluding points so that Jill doesn't yell at me.
No, you're fine.
Oh, then I'm going to show the slide. She shouldn't have said that. I'm going to hurry. So, theories of adult learning theory are critical. And people like B.J. Fogg at Stanford, Daniel Pink, all the rest of the people that are writing on the new pedagogy of adult learning theories, I hope you're embracing these people. I hope you're embracing these thinking. I hope that your apps and the things that you are working on is taking good advantage of how people think. You see, it isn't magic. It doesn't just happen magically. There are fundamentals, awareness. Does the person believe that they're going to get anything? If you're a kid, I'm going to live forever. Why the hell do I need your stuff? It doesn't matter to me. If I'm worried about being vulnerable, that's different. Do I believe that if I take action, it'll mean something? How likely is it that my actions will have an effect? There are critical things like, do I actually know how to do the thing? Am I actually competent to use it. So skill building, self-confidence, small strategy steps. That's one thing that the people outside of your world are finally realizing. You can't just say, eat the whole thing at once. Small steps become important, and there's much more willingness to do it. And if all that doesn't work, tie the doggone intervention to financial incentives for the patient. And that's the new healthcare benefits that have patients with significant skin in the game. You've got to have the money effective. And then you want to make sure you know value. Does it work, for whom, and under what conditions? Is it additive, or did you just add more cost to the system? And that's going to be fundamental. This is where you're going to be mad at me as I end up. You're going to be very upset with me because I'm going to ask you to do more things. I thought this was really a great quote. And by the way, I think Google is terrific, and I love them, and don't get mad at me. But Google, Amazon, and Microsoft have regularly visited the FDA. Regularly. But when they came out, he's like, man, it's regulated. I mean, yeah, you think? Like life or death? Like you think people making decisions about whether you live or die, you might want to regulate a little bit of that because it's kind of important. The tragedy would be, of course, if everybody decided that they hate the FDA and let's skate under the radar and make stuff that's sort of kind of good, but not really. Well, what's that? I mean, did you just do this to make a whole bunch of money? The hell with the health part? You're in the wrong industry, folk. If you came into this thing just to slip through the radar real quick, make a buck and get out, I'm not talking to y'all. I'm talking to the other people. So the people that actually want to do something for the world and make money because they did the right thing. So I'm going to skip this. Basically, this is just saying, again, that what happens in our business is that we don't do diddly squat very well in terms of doing the research to prove the value of what we do. So I'm actually happy that UCSF has sponsored this meeting because the academy has to be in partnership with you to do the research that allows you to prove value. And that's the point of it. The last word I'll say is reimbursement. Remember that the delivery system is being paid in a different way. Whether you are cynical or not, fee-for-service as a sole mechanism of making money, of getting paid, is dead. It's going to die. It is. It's going to be a slow, torturous process. But at the end of the day, fee-for-service is not going to be around. No one is ever going back to, hey, I'm going to pay you for piecework. You can do anything you want. I don't care. You tell me you did it, I'll give you a check. I don't care about the outcomes. Doesn't matter to me. That ain't never going to happen. So whether you are a cynic about whether the new value-based payment system for physicians and hospitals is going to be effective or not, it is going to go forward. Okay? You're not going. Now, it'll change. There'll be moderations. What does that mean? Last year, 50% of the highest cost consumers used less than $5,000 of health care the year before. 50% used less than $5,000 the year before. In other words, the delivery system doesn't know who's about to be sick. But our data tells us who's about to be sick. So now the doc has an incentive for how they're paid, and the consumer has an incentive because of new benefit designs to both have a conversation about turning off the spigot of preventable illness, identifying early and working together. This is a huge opportunity for you that brings the two pieces together. We are so happy that you're doing what you're doing. I am so proud to be a part of your movement. As the president of the ATA, I will tell you that my job is to be your servant. If I wish I had more time. There are like 12 other things I would have told you about: broadband, fighting for more broadband availability, which we're doing with the FCC. There's so many other things that we need to get at. But if there's something that I should be doing to support you in being able to grow and develop your businesses, please let me know, because I understand what's at stake. There are larger purposes and transcendent values that are associated with whether your businesses succeed, whether we live, whether we prematurely die, and the quality of that survival. In the midst of this horrific set of difficult challenges, there has to be a ray of bright light innovation. That's you. just make damn sure that your innovation is not just innovation for innovation's sake. Thank y'all.